So if you missed any of those and want to go back and listen to them, they are available on x-cel's website and on their Facebook page. Today we're going to talk a little bit about the new ABCD classification system for keratoconus. It's something that it may not be 100% applicable to optometrists and contact lens fitters, but as specialists in keratoconus, it's something that we do need to understand, at least in a broad sense. And so that's what I want to introduce today is what does it mean? I've heard a lot of talk about it now at conferences, especially ones that deal with corneal specialists, and they're starting to use the ABCD system to determine when surgeries are going to be performed and what type of surgery will be performed on patients with keratoconus. So I think it's a good idea to have an overview, have a knowledge, and be able to communicate that A to the patient, and B, communicate to referring ophthalmologists who use the system and send you information regarding the system. So a couple quick disclosures. I'm a consultant speaker for x-cel, and I'm a committee chairman for the Scleral Lens Education Society. This is a quote from a couple years ago that basically addressed the fact that there was really no clinically adequate classification for keratoconus. We're not talking about categorizing keratoconus as a nipple cone or an oval cone or a globus cone. We're talking about progression analysis and functionability. How well do these patients function in an everyday life, in their jobs, and when is it time to abort contact lenses and go toward corneal transplantation or some other procedure? And it's more important now than ever. If you look at a couple decades ago, there was really two things we could do with keratoconus, right? We could fit them in rigid contact lenses when they got bad enough that glasses didn't work, and then if that ended up leading to scarring or acute eye drops that never quite healed up, wherever it might be, they got a full thickness corneal transplant or penetrating keratoplasty. Now we've got new options. We have corneal crosslinking, which we'll talk a lot about today. Because there's not a ton of information that's relevant to us on this classification system, I put some cross-linking slides at the end because I thought they tied in nicely to this lecture. We have DALK. If you're not familiar with deep anterior lamellar keratoplasty, basically it spares Descemet's membrane and the endothelium. The endothelium is the #1 source of rejection for corneal transplant. So if we can keep the patient's own endothelium intact, the chances of rejection are going to be much lower. It's a procedure that requires a good amount of skill. If a surgeon doesn't do it properly, you can get some haze in the interface between the host and the graft tissue. But it's getting better, and it's going to become more and more of a viable option for certain types of patient with keratoconus, as we'll see. Some patients are going to have an endothelium or a posterior corneal surface that accepts DALK, and some will still need the full PK or penetrating keratoplasty. Corneal rings have been around for a little while. They never quite caught on. Some surgeons still swear by them. Especially with corneal GP fittings, there were some advantages in that you could take a cornea that was relatively healthy and clear but excessively steep, and you could normalize that shape or flatten it. Other than that, not a whole lot of advantage. It definitely does not stop the progression of keratoconus like cross-linking does. And then finally, contact lenses, which I know we are all quite familiar with. So this new classification system, the ABCD classification system, really deals with two things. One is, when do we need to intervene surgically, or when does an ophthalmologist need to intervene surgically? And then which of these surgical treatments is going to be best for that patient? You know, it's not all just PK or no PK. Now we have options that can fit a wide variety of keratoconic patients, and some might be better than others for a certain type of cone or a certain type of cornea. Currently, as optometrists, like I said, these systems aren't quite as important to us in our own clinics, although it is kind of nice to have a way to monitor progression year to year. I think for most optometrists, we just look at the numbers that are available to us when we look for progression. When we talk about whether or not to do cross-linking, whether it's time for a PK, we look at things like, are the Ks getting steeper? Is the topography getting hotter or redder? Is the pachymetry getting thinner? And then finally, the biggest thing I know I look at when I decide whether or not I'm going to refer a patient off for a consult for some sort of surgical intervention is how well are they functioning? You know, how much vision do they need, and how much can I get them through a rigid gas permeable lens? And if I can meet their needs, we'll keep them out of surgery as long as possible. And if I can't, then we have to start exploring that surgical option. So, and I think that's kind of most optometrist guidelines for when do we do surgery, or at least when do we refer, is based on functionality of the patient and progression of the indicators that we look at. So the old system for determining or staging keratoconus was called the Amsler-Krumik system. It was actually developed in the 1940s, so it's been around for a long time. It's still used today. If you go to Asker's, or you go to some of these big, that's more refractive, but some of the big cornea conferences, you listen to some of the lectures on YouTube, you'll hear them mention the AK system as a stage 2 or a stage 3 as their determining factor of when they do surgery. So it's still used today, but the system itself predates a lot of the technology we have available to us, and for that reason alone, it's outdated. It predates tomography, like an OCT, which we can use to really isolate thinnest areas of the cornea and progression. It predates topography even, so we couldn't even map a cornea back when this system was developed. It basically breaks down keratoconus based on a 1 to 4 scale, based on 4 different criteria. One is spectacle refraction, one is central corneal thickness, one is central keratometry, and then the presence or absence corneal scarring. And so if we look at the Amsler-Krumik system here, you can see stage 1 to stage 4. Stage 1 is very mild form of the disease with a little bit of eccentric steepening, myopia, which is obviously a very general term, over 5 diopters, and then it separates K values, which obviously increase as we move down or up the stages on this chart here. So it sort of makes sense, but there's a lot of ambiguity, and there can be a lot of overlap. You can have somebody who might have a K above 48, but not have a prescription above a -5. You might not have scarring in a patient with an extremely steep K who might fit into a category 4 based on Ks, but there's no scarring, and so they wouldn't be a category 4. So it's far from perfect, but it was a start. You know, back in 1940, I think it gave people at least a general idea to monitor progression and get an idea of whether or not transplantation would be advantageous. The shortfalls, though, are pretty glaring these days. The biggest thing they look at is central pachymetry, or one of the things they look at is central pachymetry. And obviously we know now, with our ability to use tomographers like OCTs, we can do a map of the entire cornea, taking hundreds of data points, and decide where is the thinnest area. And with keratoconics, the thinnest area is usually at the apex of that cone. And we know with keratoconics, typically the apex of the cone is not central. So doing central pachymetry on these patients may not really give us the best determining factor when it comes to monitoring progression or severity of the disease as it stands at that very moment. It doesn't really distinguish normal versus pathological either. Corneal eccentricity or eccentric steepening really would be kind of considered anything with an angle cap over about a degree or at a degree or over, and really a quarter of the normal population would probably qualify for that. So if you take a quarter population, not all of them will have keratoconus, but a lot of them may have more than 5 diopters of myopia, or I'm sorry, up to 5 diopters of myopia, and K reading under 48. So there's no area on that chart for normal or the absence of keratoconus. There's also no posterior corneal data. And the more we have access to things like orb scans and pentacams and all these different instruments, we know that the posterior cornea can, in some cases, or in a lot of cases, show steepening before we see anything on the anterior cornea. And so when we look for patients who would be good candidates for corneal crosslinking, obviously, when we talk about crosslinking, we want to do that as early as possible for these patients. We need to find the earliest possible changes. And by ignoring the posterior cornea of patients who might be at risk, we may be missing the first opportunity to hit these patients with corneal collagen crosslinking. The other thing that's pretty amazing is it doesn't account for best corrected acuity. It accounts for prescription, but prescriptions, spectacle prescriptions can vary so widely with keratoconic patients. And obviously a much better functional test would be best corrected acuity. But the Amsler-Krumik system ignores that. So a lot of shortfalls there that are hopefully going to be made up for with the new ABCD grading system. It utilizes modern technology that allows us to pinpoint the thinnest portion of the cornea, allows us to look at both the anterior and posterior curvatures of the cornea, and then it also takes into account corneal scarring. It also utilizes best corrected spectacle distance acuity as opposed to prescription, which really isn't a good determinant. One downside as an optometrist to the system is that the only system in the United States that can run the ABCD classification system is the pentacam. You have to have a pentacam to do it. The pentacam basically does all the work for you, but it'll spit out the numbers. I don't have one in my practice, but a lot of the doctors who refer to me, the ophthalmologists who refer to me, send me Pentacam images, and so I am exposed to them quite a bit. But what the Pentacam actually does, and the way this data came about is kind of backwards, but essentially they find the thinnest point on the cornea and draw a 3-millimeter circle around it. And the thought is the thinnest point of the cornea is going to best correlate with the apex of that cone and give us the best sample size for measuring the anterior and posterior corneal curvatures of that cone that kind of best represents the overall cornea. So you take that best fit 3 millimeters around the thinnest part of that cornea, and you measure the anterior radius of curvature and the posterior radius of curvature. And again, the Pentacam will just do that for you. There are other systems that do this. They're just not available yet in the United States. And I think hopefully we'll have some, or at least some of our current systems will be able to be upgraded in order to run this type of software. But it's very, very simple from there. This chart looks a little overwhelming in the beginning, but it's really simple. Again, we have the A, B, C, D system, classification system, and then we kind of throw corneal scarring off to the end as sort of like a modifier, with a minus being no scarring, a plus being mild scarring, and a double plus being heavy central scarring. But for each of these letters, A, B, C, and D, each one will be assigned a stage, 0 through 4. So A will either be a 0, 1, 2, 3, or 4, B, C, and D. And that's going to allow us, when we see the whole score, A through D, to determine exactly what area of the cornea is involved and exactly what kind of treatment is going to be best for that patient. Another big advantage here is you can see stage 0 is basically the absence of keratoconus. Somebody with 20 or 20 better vision, who has normal pachymetry and normal anterior and posterior radius of curvature. Again, it's automatically processed. It shows up in the keratoconus staging display, and here's how it reads down here. You have to obviously manually enter their spectacle visual acuity for D, but everything else will be put in there for you. A is the anterior radius of curvature, like we talked about. B is the posterior radius of curvature. C is the thinnest point on the cornea, the thinnest pack, and then D is the vision. And the readout looks like this down at the bottom here. So this is a good example of somebody who would really benefit from cross-linking, who might be overlooked with other systems. A is 0 means anterior curvature is actually normal. And so that would tell us we did topography. We're not actually going to see any changes on that anterior surface. With B at 4, the posterior surface is going to be very, very elevated beyond normal, and therefore we're going to see early keratoconus on the posterior cornea. We're going to have a thin pachymetry reading, so that's going to be much thinner than average. You can see at 381, and then D, visual acuity, is going to be 20/20. So if we just did topography and visual acuity on this patient alone, they may look normal because the anterior surface is normally curved and the visual acuity is normal. Where we're going to see the abnormalities is in the posterior corneal curvature and in the corneal pachymetry, or the thinnest point in that cornea. So again, a really good way to detect early forms of the disease, and then again, we'll just watch these numbers year by year in different patients. If A continues to increase year by year, we know that anterior cornea is getting steeper and steeper. Same with B, C, and D. So again, allows you to easily measure progression and determine corneal collagen cross-linking viability. And then again, it helps those surgeons determine exactly what type of surgery is going to be best. So a few examples here. If you look at this top one, if they have a relatively steep anterior surface, a close to normal posterior surface, but they're thinning quite a bit and the vision is very poor, D4 equals 20/100 or worse, and they have heavy central scarring, which is probably causing that decreased vision, a doubt could be very beneficial to them. The posterior cornea is healthy, so why don't we just replace the area that's scarred, right, the stroma, and leave the endothelium and descemet membrane intact. Whereas if all layers are extremely ectatic, the anterior and posterior cornea, we have excessive thinning and very poor vision, there's not much to save on that posterior corneal surface, and we'll have to do a full penetrating keratoplasty in that situation. And then finally, if all we have is steepness, the anterior and posterior curvatures are very steep, but our thickness is good, relatively speaking, our vision's good, relatively speaking, we can just fit them in a scleral lens, we can do corneal cross-linking, or we can use rings in that case in order to normalize that corneal curvature and bring the steepness down to a more manageable size. For optometrists, there's some drawbacks to this. Obviously, without a Pentacam, we can't take these measurements. We can get them. One thing I do for patients, especially if they're early and I have a reason to suspect keratoconus, is I'll co-manage just a Pentacam with a local ophthalmologist. I have one in town, and they can simply build a technical component. You can build the professional component and do the write-up on the exam. They'll fax to you, keep in your chart, and you can use that to kind of monitor progression, especially in young patients. I'll do that. If I catch an early patient, I suspect keratoconus in their teens, I'll send them off just for a Pennicam. I'll have these readings done, I'll have it come back to me, and I get a few bucks in reimbursement, but really I'm able to better monitor their condition, and it makes the system more viable to me in those patients where I have access to that information. Another problem with the system, it doesn't take into account best corrected vision with a rigid gas permeable lens, which obviously tells us a lot more about functionality than best corrected spectacle acuity. That being said, this is more used by surgeons and ophthalmologists, so they don't really care as much about best corrected RGP acuity, but for us, that's going to be the determining factor as to when we're going to send them off for the next step, whether or not we can correct them properly with a scleral lens. So that's the ABC system. Like I said, I think it's a good idea to have at least a base of knowledge so that you can use it to interpret the results on your own or discuss with surgeons who you refer patients to. One of the big things we use it for as optometrists, though, is going to be monitoring progression for corneal collagen crosslinking. So I just have a few slides here. I'm assuming most of you are pretty familiar now with crosslinking, but if you're not, I want to at least give you a good overview of what it entails and what your patients can expect day of surgery and day after surgery. I've done about a dozen patients now, both epi-on and epi-off, co-managed with local ophthalmologists, and the results have been good. Obviously, this has been going on worldwide for well over a decade now, with amazing results. I did an externship in Australia, and every single patient, I externed with a scleral lens specialist, John Mountford, but every single patient he saw was sent over from the university. All of them had been cross-linked, and that was just the system over there. You got cross-linked, you got fit with a scleral lens, and you went about your life, and you saw great, and you didn't have to worry about progression and corneal transplantation down the road. So cross-linking, it stiffens the cornea up by increasing the connection between collagen fibrils, mainly in the anterior cornea. It uses UVA light and riboflavin to increase rigidity, depending on the publication, between 70% and 400%. It's more applicable to young people because our cornea is naturally cross-linked with age. 40 is kind of the general cutoff. After 35 for me, though, if they're stable, I don't really worry about cross-linking, especially right now, because while it is the FDA approved, insurance coverage is sparse. I have had some patients who got their insurance to cover it, but it's always a battle. And once we get a CPT code from CMS, that's going to become a lot easier, obviously. But at this point, I'm not going to do it unless I know this progression, or they're under 35, I'm going to recommend that immediately. So again, that's kind of what we just talked about there. It's not good for a patient who's right on the edge of corneal transplant for a few reasons. One, you have to have enough thickness in order to do this procedure. The recommended thickness to do cross-linking is 400 microns. That being said, most ophthalmologists will use a hypertonic solution to kind of swell that cornea up to get the proper thickness necessary. But if they're way down at 200 microns and they're kind of on the edge of a corneal transplant, this is not going to save their vision. They're still probably heavily scarred at that point. So we'll just err on the side of transplant when it's necessary. There's two forms. There's epi-off and there's epi-on. Epi-off is the current FDA-approved format. This requires debridement of the central 8 to 9 millimeters epithelium. Co-managing these patients will be a lot like co-managing a PRK patient. The good news is most of the patients we do this procedure on are young and healthy. If you've done a lot of PRK post-op appointments, you know sometimes it can be very difficult to get these patients to re-epithelialize, especially if they're smokers, especially if they're diabetics. If you have a 21-year-old kid who's healthy, he or she is going to be able to re-epithelialize very, very quickly. And so 5 to 7 days typically before you can remove a bandaged contact lens. And then you still have to wait for the vision to clear up, which can take a little bit of time. To do this procedure, they debride the epithelium. It's just the 0.1% riboflavin every 5 minutes for 30 minutes to saturate the cornea. You expose it to that UV light, and then you continue to apply the riboflavin every 5 minutes during the 30-minute exposure. And that's really it. You get a bandaged contact lens, an antibiotic, and you're out the door. The epi-on is done pretty much the same way. The only difference is they add some components to kind of chew through some of the epithelium to really increase penetration of that riboflavin. So BAC, EDTA, and gentamicin are typically applied to the riboflavin in order to make sure it gets proper penetration into the anterior stroma, which is where we really want most of the cross-linking to take place. The one thing you'll notice with epi-on, epioff obviously comes with inherent discomfort because of the large area of abrasion that's created. Epi-on patients, so a lot of, not all, but a lot of them will complain about really severe pain 24 to 48 hours after surgery. Not all of them. Some of them are completely comfortable as soon as surgery's over through the rest of treatment, through the rest of healing. But on occasion, you do get people who complain about this really sharp shooting pain, and to the point some ophthalmologists actually give a few pills of Vicodin or some other opioid analgesic in order to deal with that, just for the 24 to 48 hours after the procedure. Some studies do show higher incidences of corneal haze and infection in the epi-on procedure. I'm not 100% convinced of that. Not all of the studies show that, and I think as the FDA trials continue to move on, we'll see some more data that will probably put them a little bit more similar as far as efficacy goes. 12 months out, they both show the exact same as far as being able to stabilize the cornea. And most publications will say you get about a 2 diopter regression in max K. So it's not dramatic. And when it comes to scleral lens fitting, I think people kind of overreact to not wanting to fit a scleral lens on a patient who's going to have corneal collagen cross-linking. Most patients who are going to regress about a diopter. A lot of patients are going to stay perfectly stable, and very few might still advance a little bit if they're going to advance anyway. And they'll do so before the treatment really takes hold. But even a diopter of regression may give you an extra 50 to 80 microns of clearance on your scleral lens, which isn't the end of the world. Obviously, it's going to limit some of the oxygen we're getting to that anterior surface, but it's still, I would say, it's better to have the patient seen as good as possible through a scleral lens for as long as possible, as opposed to making them suffer through blurry vision and spectacles or whatever other vision correction device they were using up until the procedure. So I found change, but very little change following cross-linking in these patients. So I'll go ahead and fit them ahead of time. They'll be out of sclerals for a month to 2 months afterwards until they're comfortable, and the ophthalmologist sends them over to me usually about a month out, and I'll put them back in sclerals at that time. And then I'll watch them for changes in fit and power. But usually it's going to be very mild. Remember, we're not cross-linking the sclera. So the part of the contact that actually rests on the eye won't change. All it's going to change is your clearance and possibly a little bit of your power, just because of the refractive index differences between the contact, the tear film, and the cornea. So don't be afraid to put a scleral lens on before and keep it on as treatment goes. It can be repeated. I recently had a 15-year-old with very advanced keratoconus. He was cross-linked, and the surgeon pretty much said you'll probably have to have this done again within the next 5 years. But for the most part, if they're over 20, moderate to mildly severe cones, one-time treatment is going to be sufficient to get them through to the point where the cornea continues to naturally cross-link over time. And you do see sometimes a little bit of improvement in VA, but that's rarely dramatic. I don't get patients' hopes up with after cross-linking you'll see better through your scleral, or you'll see better through contacts. Obviously, it's not going to get rid of the ectasia, at least not at this point. So make sure you educate your patients that you will still need to come back and be monitored for a scleral lens. This is just for halting the progression of the condition. So that's all I have. Kathy, are there any questions about either the classification system or corneal collagen cross-linking?
We have one question so far, and it is it possible to get a link to the ABCD chart and the Ansler K-grid?
Yeah, I can forward those along. If you type in both of those names on Google and go to images, they'll come right up. So that's probably the best way to do it. If you can't find them, though, I'll be happy to pass that along if you want to send an email after we get done. Is that it?
Doesn't look like we have any more questions. Is there any advantage to CXL someone over 35?
Well, one area where you really want to watch for it, and I've done it before and I'll do it again, is post-refractive ectasia. Obviously, those can occur at any age, and you want to stabilize those as quickly as possible. So I had a lady who was 50 years old who had post-LASIK ectasia, and we cross-linked her. And I think, yeah, there definitely is an advantage as long as there's progression. If the cornea is perfectly stable, the vision's perfectly stable, there's no reason to cross-link a patient. But there's exceptions to every rule. So you could have a patient who's 45 and still showing progression in their keratoconus, and that patient would benefit from cross-linking. So I don't think it's fair to rule out anybody. I don't push it as hard over 35. I make sure I can justify their out-of-pocket cost at this point with showing progression in their keratoconus.
Okay, if patients develop opacity, can we still cross-link?
Yeah, and that's a great question. You can cross-link through any scarring or opacity. That 15-year-old who I said we cross-linked recently already had central scarring. They don't think it affects the cross-linking. If anything, it might not penetrate as well, but the area that's scarred is going to have scar tissue and is probably going to be more stabilized anyway, and it will cross-link all around that area of scarring. So the two ophthalmologists that I work with will both definitely cross-link on top of scarring. And it's a good indication to do it, because if they started scarring, but they still have good vision, you can stop it. You know, if you don't do anything about it, they're probably going to develop more. So they're some of the best patients to cross-link to try to a last-ditch effort to save them from needing a corneal transplant.
That looks like that's all the questions we have for tonight. If you, by chance, have missed any of the presentation tonight, it will be on our website under education. Drew, do you have anything else?
I don't think so. I think we have one more this year, billing and coding in early December. Is that right?
Yes.
So look for that email, and I appreciate everybody coming out.
Yes, thank you so much for joining us.
Thank you.
Good night, everyone.